How do I go to the next? Good evening, and profuse thanks to Professor Dr. G.V.K. sir for giving this opportunity again to interact in this 3D con. I was couple of times the opening batsman. Today I am the night watchman. Last, so not the closing one. So it's an overlapping talk. Thanks to Sir Prabhakar sir for introducing the holistic metabolic cardio-renal perspective of diabetes, more than vascular. So we will focus on diabetic kidney disease. How do we currently diagnose? Is there anything new happening? What else we can do? Many of us know all this. There are some semantic differences. I'll come back to this. Interestingly, to know academically, diabetic kidney disease is not the same as diabetic nephropathy, strictly speaking. Nephropathy is what we all diagnose. Presume that every patient has nephropathy, which means the classic hyperglycemia related glomerular changes leading to proteinuria, and that's what you detect. However, as you know, diabetic patients are prone for any other kidney disease like any other person. So if you have a clinical suspicion of any other condition, how do we do that? We will come to in the next couple of minutes. Simple clinical parameters are there. But in general, type 2 diabetes, in type 1 diabetes is most often the lateral one, that a long-standing type 1, more than 10 years, relatively not that well controlled. You expect typical microangiopathic glomerular changes leading to diabetic nephropathy. So we know that this kidney and now heart is also included in our screening, provides an opportunity. Kidney also provides a window to the problem in the heart. So any early albumin detection is an indication that there is something, we all know, diabetes causing in the vascular. So in fact, the microangiopathic changes are the definition of diabetes. We define diabetes by retinopathy and probably currently by nephropathy also. So they both go together, and it is you should suspect whether the patient really has diabetic nephropathy if he doesn't have retinopathy. All these need a lot of clinical examination things, and the detection of early albumin is a very good parameter. So most important point from this slide, a take-home point for all of us is, not every diabetic patient who comes to your clinic will have only diabetic nephropathy. Look at other conditions. In the previous case, SGLT2 inhibitors were stressed beyond, I can agree that for that talk it required that stress, but please use your clinical judgment. We have had in our tertiary care big hospitals, every time a patient with pyelonephritis only continued on SGLT2 inhibitor. This should not happen in spite of being hot. He will come back with another serious kidney problem. And look at other issues, a patient with prostate issue, patient with a reflux condition. There are a number of kidney diseases. You should be aware of the other conditions. When to suspect that this is not the routine diabetic nephropathy is what is our aim. So this is one such study, though old. I was talking to 3 or 4 of my our nephrology friends. They said that, in our hospital in Ramchandra also, they have done a small study from the retrospective analysis. Out of some 200 odd diabetic kidney biopsies, almost 40-50 patients, which means somewhere around 30 to 40% have non-diabetic nephropathy. That is cutting across many such papers. So always take the help of our nephrology colleagues, should a biopsy be indicated, etc., rather than just saying, I will hike up the ARB, I will add SGLT2 as a nephropathy protective drug. Please use your. I'm spending extra 2-3 minutes here to emphasize that overall general medical point. And this is what we were discussing, the nephropathy, which is classic, which means the glomerular basement membrane undergoing changes, podocyte undergoing changes, mesangial inflammation, expansion, all these are common things. You recite the same thing, and inflammatory cells infiltration, ultimately leading to leakage of albumin, initially at a lower amount. We don't technically call it now microalbuminuria because people thought that the albumin itself is different. It is moderately increased albumin or severely increased albumin. We don't call macro now in that to emphasize that this albumin is not different from other albumin. All are same, only the amount is less. So the pathogenetic mechanisms, put it very simply, involves and revolves around hemodynamic mechanisms, the afferent and the efferent arteriolar dynamics, the inflammatory pathways, Of course, we are all involved in the top factors, metabolic factors, hypertension, glucose and lipids, and the subcellular mechanisms involving oxidative stress. Broadly, all these are targets also, and they are all the pathogenic mechanisms also. And obviously, any condition like a non-communicable chronic condition like diabetes-related nephrotic kidney conditions will have modifiable and non-modifiable factors. We have to focus on the left side here. And many of the other conditions, especially the genetic susceptibility, which includes ACE gene polymorphism, etc., are studied nicely in our population also, to show that you will get a classic family history of nephropathy in many of our patients if you dig into what happened to them. And very often glucose control is attempted only late in the course of the disease, due to which they come with advanced kidney conditions to us. So in addition to this confusion, we have patients who progress lowering their GFR with no albumin at all in the urine. You will do a routine, diabetes packages today do microalbumin as part of the package, and that will be always normal, but the patient's creatinine will be going up. This not only indicates that you are probably not dealing with diabetic nephropathy many times, but it could also be that even in diabetic nephropathy, a subset will not have albuminuria for reasons beyond, you can guess that, but ultimately at most 10-20% may have these kind of conditions. So these are all the indicators to suspect that the patient has a routine diabetes related nephropathy and not non-diabetic kidney condition, which includes duration of diabetes, long-standing glucose control, how good or bad is it, blood pressure control, how bad is the albuminuria without active sediments in the urine, and whether he had prior kidney diseases which is contributing. This was the age-old slide, Mogensen in type 1 diabetes, from which we learnt a lot. In type 1 diabetes, we can date the onset of diabetes correctly. So after the 5th or 10th year of type 1 diabetes, if it is not well controlled, predictably they develop hypertension, and hypertension is a clear indicator that the type 1 patient is going into nephropathy, and all these are well documented, and with which we staged the hyperfiltration phase, then the microalbuminuric phase, overt proteinuric phase, and the end-stage kidney disease phase. But this doesn't hold good for type 2, and that is why this grid kind of approach is being done. This is not specific for diabetic kidney disease, but can be very well used in diabetic kidney, where we want to know both the albuminuria as well as the GFR. The GFR is today very easily estimated. We don't use the Cockcroft and Gault formula for various reasons. Now it is based on the CKD study and the MDRD study. For the EPI study, it's all freely available on the net. You have to use it, but so based on GFR and albumin, you can classify whether the patient has G1A1, G1A2 like that. And the green, yellow, orange and red says that severity of the condition. Ideally, a primary care person like many of us should be referring to nephrologist in the lower segments of this, where either the proteinuria is disproportionate and not getting controlled with your standard stiff dose of the currently available agents, which includes even SGLT2, or the creatinine is worsening. That means eGFR is decreasing in spite of your stricter control, with which we need the specialist nephrologist help. Otherwise, most of us will be in this green and yellow phase, where we have to definitely treat aggressively blood pressure first, then glycemia, then lipids, of course other things we'll touch upon. So I'm repeating here, any patient with sudden onset worsening in proteinuria, think of non-diabetic kidney disease. Gradually increasing over a period of 2-3 years, repeat values are mildly increasing is diabetes. The GFR reduces very slowly in a general diabetic nephropathy. So high proteinuria, rapidly increasing proteinuria, rapid worsening of or increasing in creatinine. Please see urine routine also. Don't do just microalbumin. Urine routine, as we all been taught in our undergraduate and postgraduate days, the stethoscope for a nephrologist. So simple urine routine examination, even the automated multi-sticks also will give you whether RBCs are there significantly, pus cells are there, etc. And today in the era of SGLT2, everybody will have 3+ glucose. Don't see that. See the other ones. You will see that if they have active sediments of RBCs, disproportionate pus cells, And if their proteinuria is disproportionate to what you expect, then suspect non-diabetic proteinuria. The simplest examination, if it was an MD exam, we used to be pulled up for not examining the fundus. If you are not trained to see fundus well, first see the fundus. If the fundus shows retinopathy, you are most likely dealing with diabetic nephropathy. Suppose fundus says only hypertension and no diabetic specific changes, then suspect something else is happening. Then get an ultrasound. So in this order you have to go. And everything today, what is happening in our practice is, sir, echo ke avlo soltaru strain la na paathathe illa, frankly enga report la routine varudhe illa LA strain la. E preme na kashtappattu kathunna ana adu apply panna neenga solradhu aduve thappuntinga ipo. I am getting worried now. So routine ultrasounds, as you know, are many times done. Templates are being typed, and kidneys are not, unless you say it is for kidney we are asking. So any asymmetry, size, etc. has to be carefully looked at. So in every step of whatever these kind of discussions in this CME, a trained eye, sir, you will see what only you are, already you know. What your mind does not, your eyes will not see. For every step what we require here. And apply the right tests so that we don't subject everybody to elaborate further testing. So without albuminuria also, if the patient has significant hypertension and GFR is reducing, definitely it indicates non-diabetic kidney disease, go into that segment. So generally for all practical purpose, a primary care level of diabetes practice, please do urine routine and urine albumin creatinine ratio in all your patients at least once a year. If there is an abnormality, repeat it in the next 3 to 6 months, especially when the glucose control and blood pressure control is better. Because if you see the standard way it is taught in bedside, anybody has, a recent urinary infection, stress, fever, pregnancy, or uncontrolled glucose, uncontrolled hypertension, there will be a mild proteinuria. You have to repeat on another day to say that it's a persistent increased albumin excretion, so that the kidney specific thing is addressed properly. So repeat is a word. And you see here, this slide is just to tell you how much of research each one of these molecules, some 5 PhDs would have been done somewhere in the world, that there are every part of the glomerulus is now researched to see whether there could be any other early marker over and above your albumin excretion. All inflammatory markers, proximal and distal tubular markers, copeptin, loop of Henle, glomerulus, out of which cystatin C is reasonably very well studied, however not easily available, and standardization of assay is not there, but a very good thing. Next to creatinine, it is the best molecule for assessing the GFR as well as indirectly indicating the glomerular function. However, frankly speaking, we don't use it in our practice routinely. So the management, once you diagnose there is a persistent proteinuria, which means albuminuria in a given patient, is, I cannot overemphasize these slides: cessation of smoking, reduce or almost nullify whatever alcohol intake, normalizing protein intake. These are all new terms we can use here. Most of us are low in our protein intake. It is unfortunate that generally in CKD we advise low protein intake. However, it has been discouraged. We have to advise normal protein intake, especially non-animal protein intake in most of our CKD patients. Of course, some degree of weight reduction, GLP-1 analogs will play a role, etc. These can be touched upon. The right panel is common for any kidney disease. Avoid NSAIDs, contrast agents as much as possible. Treat infections appropriately, and use the renal modified dose of whatever other drugs you are giving for other conditions. All these will help in saving and protracting the declining of GFR in our patients. So early measures which are very important for all our practice is these 3 things. Good aggressive glycemic and blood pressure control first. Top in the list is always ACE and ARB. We all are very familiar with this. If the ACE is, by studies actually and meta-analysis, it's superior. However, whichever is not tolerating, go for ARB at a good dose. Add any other agent, whichever, especially the second line agents include your calcium channel blockers or beta blockers, etc. Ultimately, blood pressure should be controlled well. The targets are given here. 130 by 80 if you are not having significant CKD, or if the GFR is going below 60 or 45, you can be slightly relaxed actually. That's what the current recommendation says. The non-steroidal mineralocorticoid receptor antagonist, which is Findranone, is coming up in a big way. Being an updation in knowledge, I will add a couple of points on that in the next slide. Just to tell you that spironolactone generally we avoid in males for the androgen side effects. eplerenone, fendrenone, they are coming up. Eplerenone is also a steroidal antibiotic, anti-mineralocorticoid agent. Fendrenone is in the market, pretty costly as of today, but excellent reports with respect to diabetic kidney disease. All the studies are showing. Glycemic control, we will just touch upon two things, just to tell you that SGLT2 again, I think the whole last 2 hours, SGLT2 the hero of the day. It has definitely proven benefits beyond glycemic control in preventing the kidney problems, as well as reducing proteinuria, doubling of creatinine, progression to end-stage kidney disease, dialysis dependency. All these are prevented. Specific study, if you have to quote, is canagliflozin CREDENCE study, where the primary aim itself was to see whether SGLT2 prevents kidney-specific outcomes. Of course, lipid control, there could be some controversies here, but in general, atorvastatin will score over others in kidney issue if they is already persisting. Already creatinine is above the limits. Otherwise, in prevention, you can use statin and ezetimibe, go down on the LDL as low as possible, as has been recommended by our cardiology colleagues. So, beyond A1C reduction, there are these agents, especially SGLT2 inhibitor, which have a nice synergistic mechanistic explanation as to how it controls the glomerular hypertension. So, as you know, ACE inhibitors predominantly and ARBs act on the efferent arteriole. The SGLT2 inhibitors have a vasomodulating effect on the afferent. Overall, it is absolutely good for the glomerulus. So, this is the overall, if you combine a nice combination, if the patient is tolerating, and as he already pointed out, SGLT2 has some kind of a potassium excretory effect because of, along with glucose, there could be some loss. So, hyperkalemia due to your other agent may not come in a big way. So, it is always worthwhile adding the two together, both for your benefits, good glycemic control, and all the pleiotropic benefits we all know. So, these mechanisms, as I said already, are the main pathogenetic factors playing around nephropathy, and all the drugs. You see here SGLT2 is there on all the boxes. It is not only in metabolic factors, oxidative, inflammatory pathway, fibrotic, SGLT2. Some study somewhere is that. You are going to get one more drug in the pipeline, is the aldosterone synthase inhibitor in the near future, which is also shown to be having some benefit over and above these agents. By the way, the currently available agents like fendrenone are studied on the top of ARB and ACE. So, the benefits on the kidney are not just placebo controlled. So, we have to take it in that context, and why it is important to use that. So, this slide taken up from a good review article is to tell you kidney specific primary outcomes in RCTs. As I mentioned here, the Fidelio DKD study of fendrenone, CREDENCE study by canagliflozin, DAPA CKD by dapagliflozin, EMPA kidney. These are the main trials which are absolutely giving reassurance to us that the primary aim, they are not sub-analysis studies. And you have the endothelin 1A receptor antagonists, the avocentan, atrasentan, etc., which may come in the near future. So, that's just for academic interest as of today. And the aldosterone synthase inhibitor, which is in a numbered form there. So, these are very, very helpful evidences we are having, which we can immediately put into practice, so that the kidney prevention of microalbuminuria, micro to macro, or moderate to increased prevention, and if they already have significant proteinuria, going to worsening of CKD, all aspects have been studied in these studies. So, they are definitely helpful in these. And this slide has been already shown in a different way by Prabhakar sir, and you can see that in this, the GLP-1 analog, though has been shown to have significant benefits in nephropathy in the early stages, but prevention of CKD and mortality benefits are not being proven from the kidney perspective with respect to GLP-1. That's why you see in every one of these, SGLT2 will be there on the top of the cardiorenal benefits. So, with this in the background, as the CKD or diabetic nephropathy progresses in a diabetic patient, please remember they are more of a cardiac patient. So, they die of cardiac disease more than kidney disease, even kidney patients. So, our whole approach should be in preventing a cardiac event, and all the guidelines which are stressed on CV risk reduction will score over proteinuria reduction in those patients. So, kindly approach them as a cardiac patient. So, in summary, the last few points to re-emphasize, though diabetic nephropathy is the most common cause of kidney involvement in a diabetes patient. They may have non-diabetic kidney disease also. Kindly use your clinical judgment. And we are not going to subject everybody to biopsy. So if you have a routine follow-up patient without any active sediments, not significantly hypertensive, and his proteinuria is gradually worsening, he is the typical diabetic nephropathy patient. Today, diabetic nephropathy and CKD has scored over or taken over CGN, chronic glomerulonephritis, and everything in the most common cause of CKD and dialysis dependency is this. And albuminuria, whatever research is going on, is the best indicator, practical indicator, and kindly use it judiciously, appropriately, and follow it up so that our drugs which have been all are listed here, I am not going to repeat. The standard drugs which are all time tested now for the last 2 decades, very helpful in preventing nephropathy. So the approach is overall metabolic and holistic. See the CV risk reduction also, and keep that in your mind when you are treating your diabetic patient. Thank you very much for your kind attention.